Committee could come to order. I would like to welcome everyone to the Joint Legislative Oversight Committee on Medicaid and NC Health Choice. If we come to order, please. I'll begin by announcing the Sergeant-at-Arms. The House Sergeant-at-Arms, Doug Harris, David Layton, McKella McCall. So coming in, the Senate Sergeant-at-Arms, Jim Hamilton. Oh, okay. Yeah. Over here. And Larry Hancock. So, behind that. Thank you all very much. Any comments before we go?
Good to see you, Rob.
Good to see you. Thank you. Appreciate it. We will go ahead then as we move into the remarks from our Secretary of Health and Human Services, Mandy Cohen. Welcome back. So I look forward to it. So this morning went well, and so hopefully we'll go well this afternoon.
Good afternoon. Thanks for having us back. Look forward to the session this afternoon, which we're going to just focus on the Medicaid program. Just a couple things that I'll mention. One that I mentioned this morning, I'll mention again here in case folks missed it. On our Children's Health Insurance Program, we talked a fair amount about that our last oversight session, but just to remind you that Congress has not yet acted. We continue to be able to provide coverage uninterrupted at this point, but if we don't see action by the Senate in the December timeframe, that we will have to come back to this committee with our plan on how we're going to step through some of the challenges there, whether it's enrollment freezes or others. So we are hopeful that they will take action. The House has done that, but we need the Senate to similarly to take action. And then a bit about what you're going to hear this afternoon. I think you'll hear a number of sessions on the current Medicaid program, where we are with our budget and our enrollment, and I think good news as we step through that so far. And then we'll spend the last session talking about where we are with our move to managed care. And as you can see, we're at a pretty fast clip of putting out more and more detail on some of the policy items, and we'll talk through them, but we're going to focus most of our remarks on those pieces that we need to continue to work with the General Assembly on, where we need different types of authorizing legislation and allow us to launch the most successful managed care program possible. So that's what we're going to focus on in our last session. I believe I was asked to address again the fraud, waste, and abuse piece, same that I did this morning, but just for those who may have missed it. We were charged by the General Assembly to implement a technology enhancement that will allow us to identify places where there may be either provider fraud or recipient fraud. We've now identified those scenarios that we are going to be focused on. We have been working with our vendors to implement that. The first piece of that related to providers is something that is being implemented as we speak, and we'll have the first run by the end of this month. The second half of that, which is related to the recipients, again, a bit more complex, related to the data systems as we talked about this morning, and that will be online in the April timeframe. Again, happy to answer any questions I may not have answered this morning on that, and I'll send it back to you, Senator Heiss.
Thank you. Any questions for the Secretary? Simple enough, then. Thank you. Thank you, Madam Secretary. We'll now move to the overview of Medicaid dashboards. Steve Owen.
Thank you, chairs, members of the committee. I'm Steve Owen in the Fiscal Research Division. What I want to do is spend a few minutes of time really setting up the conversation or the presentations you'll hear from the department. And as in the past, I've tried to really use this as an opportunity to help in terms of provide some perspective or some context for these presentations. The dashboards really are intended to try to give you some insight into the drivers of spending. Specifically, what I'll be talking about in terms of spending is really what goes through NC tracks. This is not a complete budget review. It is just really focused on NC tracks and trying to highlight those things that really, as I look at it, things that I see. I'll spend some time on overall trends in enrollment, talking about some specific trends or some specific items that I see in terms of program A categories, some trends in county enrollment, ending up with really the spending. The objective, again, is not a complete budget review, but rather context. Again, the source of this, of all my information, really comes from either the DMA website for enrollment or the weekly check-write reports that the department submits to a number of folks. So let's start with enrollment. At the 1st of October, we had a little over 2,014,000 people. This is about 42,000 people less than we had planned for at that point in time. I actually did look today before I came in. On the 1st of November, we're still about 41,600 people less than we expected. So enrollment is really lagging at this point from what the rebase was set, although it is about 18.5 or 18,500 people higher than it was at June 30th of last year. The two areas that are notably different are the AFDC over 21, or the adults with children, as well as children in general. The chart, or the pie chart, really, the bar chart, the blue bars show the percent variation from budget. So you can see the children, adults, which is really your AFDC population, are two areas that have significant variances under budget. The red bars show the percent variation from last year. So again, actually the adults and the children are below what they were at June 30th in terms of October 1st of this year. So the question that really comes down to is really trying to understand why is that? Is there something changed from the time we did the forecast? Has something in the economy changed, something in the geography? What has changed that has actually resulted in a 41,000 variation? I guess the question is that expected to continue? And then what does that mean in terms of, as we look at a forecast for next year or a budget for next year, or how the program may be changing? If I drill down into a couple of categories, one category that I think is significant to note is family planning. I will start off by saying family planning, in terms of spending, is a very small piece of what Medicaid does. They spend about $6 a person per month, compared to an average of around $500 a month. So it's a very small number. But what I guess the trend line here, when you look at the growth in family planning enrollment, there were changes that occurred when the Affordable Care Act began in January of 2014. Those changes resulted in more people being added to the rolls. The question, I guess, I've had for the last year or so is at some point you would expect intuitively that trend would flatten out, or we would return to a normal trend consistent with population changes and so forth. When you look at family planning, since December of 2013, right before Affordable Care Act, family planning has grown almost 340%. The rest of Medicaid has grown just under 15%. So something is different with family planning. So the question really here is do we understand what's causing that pattern or that trend to continue? The second question is, with that level of growth in family planning and the fact that Medicaid covers more than half the births in this state, is that pattern of family planning having any impact on birth rates? So these are questions I think as we look forward, particularly as we think about a forecast for the future periods, it would be important to understand those. The next category I want to talk about, again, is children. I mentioned that children and adults with children are the areas with the biggest declines. What actually I've shown you is the growth rate. The blue line is the growth rate for the child population, and this is the aggregate or cumulative children. This is all categories whether it's the mix, the other children, the M-CHIPs. It's really all children together showing you how the trends have changed, because we've seen shift between some of the categories, so I wanted to put those cumulatively so you could see kind of a trend. It goes up and down, but I guess the significance is this year, through October, we've actually seen a decline of about 0.8%. That same period last year, we'd actually seen children increase by 1.5%. If you look back at some of the earlier years, children are the areas where we've always seen significant growth. So again, we go back to the question is, can we identify some of the reasons that this is happening? Is there something, what has changed? Is there something we can identify? And then the value of really understanding that is to really figure out, is there something we can, should, or could do to alter that pattern? Is it something we want to change? Is it something that we expect? So again, children, family planning, children, I think, are two areas. Having additional information as we look at a budget will be important. The next area I want to talk a little bit about is geography. And I've looked at some of the categories. There are the counties in red. There are 26 of those counties. Those counties actually had a decline in overall Medicaid enrollment during state fiscal year 16-17. They continue to have a decline for the first 4 months of this year. So we have 26 counties that have had consistent declines over the last almost 17 months. The circle on the far left-hand side, those 6 or 7 counties, or 8 counties, I believe it is, when you look at those 8 counties, they represent 57% of the decline for these 26 counties. And I guess as I looked at it, the question I kept coming back to is there something geographically different about those counties? Is there something geographically different about these counties in terms of what they're either is happening in their county? Has something happened with process or procedure within the DSS? I think, again, it's one of these things I think that's important to understand. I did, again, look at November to see how this may have changed. Of those 26 counties, 9 still would remain on this chart as having declines that began from June of 2016. So in terms of enrollment, I think that the things that I would suggest that we really need to focus on or understand better is what's going on with family planning. Is it having an effect on births? Is there something there that may lead us to understand processes within the enrollment procedures? Secondly, the child enrollment. Is there anything that we can understand there? Is there something that has changed? Aged and blind, which are our 2 most costly categories, have seen are over budget for the first 4 months, and I guess that continued into through November. Here, I guess the question I had is something happened that our composition or the attributes of our Medicaid enrollees, is that changing? Is that something that's going to continue to change? Is that something we need to think about as we do a forecast? So if I look at the total enrollment of 41,000 less people, and I look at historical spending patterns for the various categories of service, because each category, as I mentioned earlier, family planning we spend $6 a month for, or age blind and disabled we spend over $1,400 a month for. So there's a real difference when you have difference in enrollment. If I were to apply a historical spending pattern, I would expect our spending at the end of October, to have been about $18 million under budget. What was, I guess, has been provided by the department is through that same period or through the end of October, our spending for claims through NC Tracks was actually $13 million over budget. So that's a $31 million gap between where I would expect it to be and where at least what has been reported through the claim system. I tried to do a little drilling down in terms of where the areas where the differences are. There were 4 that popped out: hospital services, this is inpatient, outpatient, ER, physician services, dental, home health, and DME. These are areas that we've at least are reporting significant variances over budget as a percentage. These variances are offset to some extent by PCS being about $28 million under budget, our CAP programs collectively, again, CAP DA, CAP Children, and so forth, are also under budget by about $19 million. And finally, drugs. This does not account for rebates. This is just the actual drug spend. Another area I looked at was on the prepaid services. This is predominantly the capitation rates through Medicaid that are paid to LME-MCOs. Throughout the end of October, they were about $5.2 million under budget. Again, I think that's a blend of the fact that we have less people enrolled, less people than we expected to be enrolled. We also have seen rate increases during that period, so that offsets some of that. But on a net basis, LME-MCO capitation payments are under budget. I guess where I want to end up with is I think there are three things to think about. And the first one, really, when I talk about the whys, these are some areas that I think understanding or having more information would be helpful. Again, as I mentioned earlier, the children and non-disabled adults, patterns, family planning, those counties. There's something we can learn about those counties. And then that $31 million spending variance through the end of October. The what's to me, as you think about that, there's not silver bullets in all this, I don't think. You have to think about a variety of things. Medicaid is, I guess, as a lot of things are, is complicated. So what I've tried to do here, this chart really tries to isolate or freeze out, is we're thinking about how to use the information if we determine why these are different. It's important to understand not just that it is different, but get it componentized so we can figure out what are the things that we can do from a policy perspective or from a budget perspective to make a difference if that's what we want to do. And then finally, again, what does all this mean and what could we do with all that? That concludes my remarks. Mr. Chair, I'll be happy to take any questions.
Representative Brisson.
Thank you, Mr. Chair. Steve, you have any numbers on the actual applications and the one that I know how many applied and how many qualified? Do you have those numbers?
I do not, but I think that's one of the kinds of questions that we need to look at as we look at those 26 counties.
And I'm not sure, but I know in the last couple of years we've been doing some reevaluation with the local county offices and all, and I know that they spent a lot of time. It was a time exhaustion trying to get the changeovers because they were only able to do one case worker could only do 2 or 3 a day. They would put in a lot of overtime. Does that have anything to do? Were we overlooking or what's going on? And particularly in those counties where you said it's dropped so much.
I don't think from the data that I've presented that you can really make that conclusion. I know there was a report on timeliness and accuracy that the department provided as well as the changes there, and that might be something better for the department to respond to.
It's Dave Richard. I'm Deputy Secretary for Medical Assistance. Representative Brisson, we don't see that correlation between anything in terms of what was happening in timeliness and accuracy on this. We think there are some other factors that may be at play, including the overall population growth in those counties. But again, we appreciate Steve's analysis of this, and we'll continue to look at it. But we don't think that correlation is there.
Representative Murphy.
Thank you, Mr. Chairman. Steve, I don't know if you can drill down on this enough. You said that it was $6 a month per person per month for family planning. The total numbers have gone down, but the cost has gone up 300%. Can you break that down into what those costs generally are? Are the medications the reason for the skyrocketing cost? Is it other ancillary services or?
Actually, the enrollment is what's grown by 340,000. So the number of people that are eligible for Medicaid for family planning services have increased at over 300%. The cost really is limited to exam, screening, and treatment related to the prevention or for family planning activities. So they don't get a full range of services that Medicaid covers. And the cost has actually remained fairly constant for the last few years. Actually, I think it's down a bit from what it was 2 years ago.
Representative Lambeth and then Representative Ensko.
Thank you, Mr. Chairman. Always, as usual, good presentation, great data to look at. You might look at unemployment rates in all the counties and see if there's a correlation in unemployment rates because, I know when I first came and it was running over budget, we attributed a lot of that over budget to the fact that unemployment was very high. Now unemployment's very low, 17-year history, historical low, and there may be a correlation. And also, I find that one slide that shows the variance interesting. In the scheme of things, we still don't have a major budget variance because we spend a lot of money on Medicaid. But it does jump out at me that dental and home health, the magnitude of dollar variance versus the spend is pretty significant. The other two, we obviously spend a lot of money on hospital and physician services. Physicians are paid so well.
Seems like hospital administrators are paid very well
and I
also.
look at Dr. Murphy when I say that. Hospital administrators don't get paid much at all. Home health and dental, though, as a proportion, is very high as a percentage. Have you done any drill downs into those? It's great that people are taking advantage of the dental services. I get a lot of questions, actually, about Medicaid dental, so maybe they're finding their way to those dental clinics. I don't know.
I think you're correct. As you drop down, I have not done any real drill down other than identify where the categories or where the variances are. The home health and DME as a percentage is probably the largest variation. I know there's some offsets with the CAP programs, but there's still, when you look at CAP and DME home health together, there's still a variation that I don't know that I can explain or even understand at this point.
Representative Dollar.
Thank you, Mr. Chairman. Well, along that line, and I have a different question, but you were talking about home health. So this is against what was budgeted, if I understand you correct, or what was assumed in coming up with the budget. But do you have numbers, and maybe get into us later, of what the actual change in year over year is?
I do have those, but do not have those with me, so I will be sure to get those to you. But you're correct. This is the variation from what the department expected to be spent. What I used here was actually is the information that they provide through the rebase.
Okay, right. Thank you for that. And then, Mr. Chairman, I had one other question, just to make sure I'm understanding correctly. You spent a good bit of time talking about the family planning, so. In terms of the component of that, is that just, and I don't know if you have any detail on it, but is that just more people accessing birth control, or is that more procedures, or do we know, just curiosity, what what increasing services have been driving that as that line's been going up?
Yeah, again, the line here really is a reflection of the number of people that are enrolled. And I think my understanding of what happened when ACA was implemented is there were changes in the way that people were identified to be eligible for this program. So as people came through and applied, either through the exchange and then were transferred to the department, or people applied, more and more people were deemed or determined to be eligible through NC FAST as well as the process. And I guess the question, which I can understand, you would see at least a first part, but at some point you would think equilibrium would resume, and we would then return to a more normal pattern. What does it, I guess the question I raise here is we just have seen this continuation of growth, and I don't know that I haven't been able to get an understanding of why that is. On the spending side, again, because it's limited to examinations, treatment, and screening, the services they're actually accessing are fairly consistent with what they were. So what we're seeing here, again, this chart really reflects the growth in the number of people, the spending at $6 a person. Obviously, that we would be over budget with that, but in the scheme of things, it's not a huge number.
So if I might follow up on that, so these are individuals that would not have prior to the ACA been eligible, that are in the current environment eligible. And so to a certain extent, as I have argued in some other forums, we have been expanding Medicaid in a sense. Certainly in this category, we have more people enrolled, and that's been going up rather significantly over the past few years. Is that the correct analysis or not?
I think that's part of it. I think these are individuals that probably have been eligible all along, but the process and the systems now identify them as eligible, where prior to the Affordable Care Act implementation and our system implementation, we just didn't catch that. I don't know if that's a fair statement or not.
That would be correct. Yes, sir.
Representative Enska.
Thank you, Mr. Chairman. I have questions in just two areas. One had to do with I understand that there's actually been a drop in the number of children per families over the past 10 years. So I'm just curious if you have seen those trends in the Medicaid population specifically. That we're now down below two children per family.
I have not looked at that. I'm not sure if the department has or not.
I believe that's because there's more child-only folks, or if you look at the distribution, there's just less adults per child, but I think the number of total children has been fairly consistent. I think that's or consistent with where we were projecting.
That
but
makes
the
sense.
number of children and their parents also being on the plan has decreased, so it's child-only.
So then, do we have automatic enrollment of children? Or I mean, is it because, or do people have to re-enroll every year with Medicaid, or do they stay continuously enrolled until they fall off?
Annually, they'll do a re-enrollment for the individuals in Medicaid. So yes.
So have we seen a fall off in the enrollment?
In terms of the numbers of children, as you can see from this chart, the numbers have not necessarily, prior to October or July 1st of this year, the numbers haven't necessarily declined. The expectation was it would continue to increase, although we actually have seen through October 1st an absolute decline in the number of children when you add together all the children categories. So we actually have seen less kids enrolled.
And my other question has to do with the home health DME. Can you break down where the increases are in that, whether it's the home health service or the medical equipment, or what?
I can get that information for you. I don't have that with me today, unless the department wants to answer.
Senator Heiss, is Dave Richard with Medicaid. Just on a home health, and we can go in and get the exact detail. I think just we do know what is driving it. So Steve suggested that you see an offset in the CAP programs. Not the entire offset doesn't equal the amount. We believe most of this is driven in the private duty nursing side, and there were several reasons for that. If you recall, we went through a long process of revising our CAP-C waiver, and when we did the revision of CAP-C waiver, we wound up having to take the private duty nursing part of that outside of the waiver. It's still counted for the entire population in terms of how we do budget neutrality, and it's managed together, but it's now on the state plan service. That was because we had a similar state plan, so we couldn't have it inside the waiver. That was a change that we had to make. When we made the change, what we had committed to is that for those families who had private duty nursing under the CAP-C waiver, when we moved it out to a place to it no longer in there on the fee-for-service side, that no family would lose any hours in that process. To do that, we had to lessen some of the rules around the private duty nursing for the fee-for-service area. So that's part of what you see in here. We expected that to happen. We're watching it daily to make sure that we don't see this continued growth. We think it's going to level. There's also a little bit of this that includes we had to do a retroactive payment for those people in the PDN that were on the CAP-C. The PDN that was inside of CAP-C, we had to wait till we pulled it out to be able to do that retro payment. So some of that's in there also.
Thank you. Quick question. I just wanted to ask. when we're looking, slide 5, we're looking at the changes in children, what have we seen corresponding in the CHIP plans, health insurance plans? Are they similarly declining? Or are they an economic shift may indicate that people moving from one area to the other? So I just wanted to know if you'd seen any in the children's health insurance plans.
And I can get you the exact information. What I recall is that CHIP or at the Health Choice Plan has not seen a similar decline. So this again, children here includes what we call MCHIP, which are those kids that technically are funded under the SCHIP program, but we've always had them as Medicaid. They're the 0 to 5 group. The MIC, which are the kids from basically age 5 up to age 18. Other children, AFDC under 21. So it's really the combination of all children, because we saw so much movement in between categories. I put them all together when I looked at the kid population.
And just to follow up on that, you showed the ACA and its changes in enrollment, but as best I remember, the only change for children under the ACA was the shift from those who were on the children's health insurance plans to Medicaid and how that was paid. There were no other changes in services and enrollment applied to children through the ACA?
The Affordable Care Act actually increased the threshold based on the federal poverty level up to 133. So what we saw was about 70,000 children on January 1st moved from what we call health choice over to Medicaid. And that's the bump you see right there around that green dotted line. The rest of it, again, if you remember, we were extending eligibility. People were past their normal 1 year point. There were a number of issues that were going on that caused that continued rise, I believe.
Any other questions or comments? Thank you, Steve. Appreciate it. Next, to also explain Medicaid and health choice enrollment, Dave Richards.
All right, so maybe we can go fast on this. All right, we can get finished. Thank you, Senator Heiss. And first of all, let me also say how much we appreciate working with FRD in terms of these issues. We value the analysis that they do, and certainly it raises questions sometimes that we haven't looked at, and it gives us a really partnership to try to look at all these issues. I'll go really quick through the enrollment forecast and part of it because Steve has just done a pretty deep dive in that. If you look at the first slide, is that we try to do this cone to show you where we're at in terms of enrollment, and then on a aggregate number, we are below what our estimates would have been on enrollment, and I think we try to drill down into these categories that work, but frankly, just a reminder is that we're talking about 2 million people, so it's a large population, and our enrollment forecasts are based on just that forecast information that we've taken from previous years, things that we're anticipating in terms of what we expect to see in the future. We actually run a model that includes a offset with SAS to do that review. And what I come away with is that we're actually relatively close in terms of the gross number, and that's really an important component to us. Obviously, the spend is different for categories, so we have to look at those. But in general, we're in a position that we're feeling pretty good about the forecast itself in terms of the overall enrollment. The next slide that we show, it sort of just kind of reiterates what Steve was going to show, is where the categories are, how they look. It's a little bit deeper dive into each one of these categories, and I know it's a little bit difficult to see on the screen, but it gives you a sort of a dashboard to look at when you want to look at those enrollment numbers and think about those categories. Again, I think as Steve walked through it, it gives a very similar view of what we're seeing. We think that there are some, I'm going to try to answer some of those questions in a second, the best we can at this point. But again, the trend, the important part about this is that we are below what our forecast would have been for enrollment, and we think that is an important place to be. And as we've done in the past, we want to make sure that line is as close as possible because it is how we drive our budget forecast. But being under is a pretty good thing. Let me maybe jump to the family planning question, because there's a lot of conversation about that. And I don't want to tell you that we think we know all of the answers to the questions that Steve did, but to give you a little insight in what we believe is going on. Number one is that as people go on to the family planning, to note that the eligibility for standard for this is at 195% of poverty. So we're talking about a relatively high number in terms of people being eligible in terms of income. And so as people moved on to this, as we're seeing that trend line go up, as Steve showed, people aren't coming off of it either. They're staying on, because typically when people are in that category is that they're making a wage that it's going to be hard for them to go above that 195. So we'll see people staying on it. So you don't see that folks coming on and off like you see in many of the other Medicaid categories that we have. And then the other thing you will see is that as people wind up leaving other categories, right? So if you're in a Medicaid category that has a lower income level, and it's a sort of the automatic process that works, but you are still eligible for family planning, you will be put on the family planning program. So that's why you continue to see this. Now, I think Steve's question is that how long will we see this pattern go? And the truth is we don't have a exact answer for you. We'll continue to dig deep into that. But we don't anticipate seeing a big drop-off in this, again, because that high number of the whole high dollar amount for the income eligibility, the fact that people aren't rolling off, and then as people come off of other categories, they will wind up going into the family planning category. So we believe that that's what you see is what's happening there. I think in the question about those counties, I think we had a similar kind of view as Representative Lameth had, is that we are seeing obviously a better employment rate, so less unemployment means that those counties tend to be counties that don't have high populations or have not had high population growth. So compared to a Wake County, for instance, which continues to have a high population growth, these counties tend not to be in that factor, and we believe that has a lot to do with this, because obviously you don't have more people moving in. You're not going to see this big increase in there. But we will do a deeper dive on those counties to make sure that we can come back to you with more information. I want to be clear, as we're looking at these things and as FRD looks at them, we will do the analysis that we should be doing and do that work. Sometimes the answer is at the end of the day is that we think these things, but we'll have to wait and see how those trends continue and do more analysis of those. But I wanted to hit those two highlights as we move to the next section of this report. In our enrollment and report, we also wanted to talk about two areas. One is the Medicaid application timeliness and the application accuracy. As we move to this slide, which again I think you can see that. We reported last month that we were seeing positive improvement in this, and if you look at this slide, we continue that through September. You'll see that the total number of counties that are meeting their timeliness number has increased to 84%. We've got a little shifting in terms of the tier level of the midsize and versus the large counties in that, but they're increasing. And I think most importantly is if you look at the statewide timeliness number, that we've improved each month. We continue to go higher in that, which is I know what the goal is for all of us, is to make sure that the counties are hitting that. I would highlight this, and Michael's here with me, and we'll talk about how we're trying to work much closer together with our social services side, so we're not duplicating things that we do the counties. But just to highlight, the reason why you see the July through September rather than going back to January on our chart is because we frankly had some data issues as we were beginning to report on this timeliness, and we wanted to make sure that what we were reporting and what the counties were responding to was accurate information. So we wound up starting really from that July date rather than going back all the way to January. Now we have the information from January, but it is really there are things inside of it that we feel were inaccurate. It would have been unfair to judge the counties on that information at that time. We have, as I mentioned, Michael and I work closely together along with the other folks to make sure that we get this work that's at high engagement from the department and DHHS leadership. And again, highlight the fact that our statewide results now are at 94%. We want to keep that going up. We'd like to get to 100%, but I think the trend line is the right place that we want to be. And then, mention these three things at the bottom, our continued actions with DSS. The DSS directors are a wide variety of individuals and have lots of different pressures on them, but we work closely together with those groups. We're providing those technical support to individual counties and continue to provide training for the DSS workers. And Michael, I don't know if you want to add some more right now in terms of the broader work that we're doing with the counties.
Sure. Good afternoon. Michael Beckett, the Assistant Secretary for Human Services. And I think building on what Deputy Secretary Richard has mentioned, it's important for us to sort of recognize that the department, there are several divisions within the department that sort of converge at county departments of social services. And so when we are trying to figure out ways to support counties to improve accuracy and timeliness for public assistance benefits, we're moving away from acting in silos. Because we need to improve our own effectiveness and efficiency in our approach with counties. Because the other thing that we do recognize is at the county level, the eligibility determination process for Medicaid is completed largely by the same people who do food nutrition services. And the smaller the counties get, the less specialization we find amongst income maintenance workers. And so in some of our smallest counties, you would find the same people who are facilitating food nutrition services and Medicaid may also be supporting sort of the energy program, that the low-income energy assistance program that happens in the winter, as well as, so I say pinch hitting for child care subsidy and sometimes even child support. And so we really are sort of working together more collaboratively to make sure that as we are sort of focusing on accuracy and timeliness for Medicaid, that we don't do that at a detriment for other components of our services like food nutrition.
I'm going to flip this slide now to the timeliness. We don't have any beautiful charts for you on this one. But no, this is a report that were submitted to the General Assembly. But to let you know that, one, I should have said this in the very beginning, but just a reminder that these are very important issues. The report on timeliness is a General Assembly report. The accuracy, the same thing, but it was generated by an auditor's report that we were responding to in the work that you've done. One of the things that the auditor said in the report, and I just want to continue to reiterate our position, is that they said that it seemed like the department had delegated its responsibility to counties. And just be real clear, is that at the department, we know it is our absolute responsibility. We're accountable for what happens in terms of the eligibility process under Medicaid, and that we take that highly serious. And it's one of the most important things that we're trying to work on today. I will tell you that it is the accuracy effort. We are working very closely, as we've talked before, with our counties. We've done several things that we believe will make a difference in here, and you can read them on a chart, but I'll just mention a couple, is that we've implemented the enhanced county second-party review requirements in reporting that we're requiring inside the legislative report. I think this goes to what Michael's talking about, is that our coordinating with our OST team and our NC FAST team to make sure that we're developing the right policy training for the counties. And county workers are doing a lot of work at this level. We have 100 counties run 100 different ways. We need to make sure that the kind of support that we're giving the counties is working for them individually, and it's not just a one-size-fits-all, because every county looks differently. We have to make sure we're doing that work with them. We're changing the way that we're tracking on utilization. We are continuing to develop enhancements inside of FAST to reduce the potential income calculation errors. It's a really important thing. The one thing I really want to highlight is that county staffing model. We've had several people, as we've talked about this, say to us is that, well, so what is the optimum county staffing pattern for this work? What we want to have is a tool, again, as we mentioned, each county is different, so the counties themselves can go inside, use this tool to make sure that what they're doing and showing is that optimum county staffing level for them, how they work in each one of those counties. Again, Wake is different than Bertie County, so we want to make sure that happens. And then finally, just to mention that we are continuing to develop the training and certification process for county staff as we go forward. We are taking this very seriously and making sure that we're doing the work locally with those counties to get this right. And again, I don't know if Michael wants to add, but that whole sense of how we're trying to do this in a coordinated way, and maybe some additional recommendation for you.
You flip this on. So Michael Beckett once again. The last bullet actually speaks to the department recommending that medical assistance programs be included with the overall effort towards social services reform. As Dave and I and our shops are working sort of better together, trying to sort of develop sort of greater efficiencies in how we attend to counties, we actually have two different bodies, two different pieces of legislation that cause us to attend to counties in silos. House Bill 630, or the Family Child Protection and Accountability Act, sort of creates an environment for us to sort of hold ourselves sort of more accountable for how counties are supervised and the work. And then there's a separate piece of legislation that actually sort of causes the same type of sort of oversight of county departments of social services. So I think, the risk in that is that we may have two different parts of the same department attending to the counties sort of separately and differently, trying to sort of hold them accountable for accuracy, timeliness, and quality services to the same client population.
Mr. Chairman, that concludes our report, and happy to take questions on this.
Questions for Dave? I'll just ask one, and this is for more directly related to Michael, I guess, that's working with the county DSSs. The state emphasis, and I know what we're doing on Medicaid and others, how is that balanced with making sure that the timeliness, particularly for food and nutrition services, we ran into that problem a little before you arrived here and those type of things. Are you seeing similar improvements across all areas of benefits in the counties, or is that, how are you focusing on those?
Thank you for the question. I was, just to let you know, I was the Director of Social Services in Durham County for 5 years, and actually, while not at the state, I was subject to the monitoring around timeliness for food and nutrition services. And so I think the point is, one of the things that we're trying to do is make sure that our efforts do not create a deficit in other places. And so when we look at our timeliness rate for food and nutrition services, we are, as a state, sort of meeting that mark of 95% sort of timeliness, and has been doing so rather consistently. While there are variations at the county level, overall, our timeliness rate for food and nutrition services is stable.
And just to follow up on those, and the other variance we saw a lot, particularly in Medicaid enrollment, was not just timeliness, but accuracy. And we had some counties that came in at 50% accuracies, versus flipping coins that was kind of coming in. And we had some come in with great numbers. Are you doing any monitoring? I know that we'd provided to begin some auditing for those, but do you have any sense on what you think is happening with the accuracy of determinations?
What I will say is that I don't have that data in front of me. My general sense is that we are improving, but we can be more precise, sort of beyond this report.
Any other questions? Okay, seeing none. Dave looks like he's going to continue for the financial update. I will say that previewing this and looking at enrollment that was up here 3 years ago, this was absolutely not any information that we had. The best we could get in the budget report 3 years ago was how many checks had we written at this point in the year, and how much we spent compared to the same number of checks written the previous year. That's really what we had, and to begin to break down enrollment information and spending. The dashboard's helpful. We got a long way to go still, but this is night and day difference from what we were looking at a few short years ago. So congratulations to everyone on that.
And Heis, thank you for that. And again, we believe this is a partnership as we do our forecasting and work with the General Assembly, and it is a large budget. So I'm going to say just a couple of words and then hand it to Roger, who has all the detail on this. What I want to say first is that as Steve presented his numbers, he was talking about a piece of the budget, and I think the way I like to think about it is that if you look at, as Steve described it, is that what he described as a place where he would expect us to be with that enrollment trend. What I want to be clear from what you'll see from our presentation is that Steve's position is absolutely correct, but that we are still in a good position in terms of our budget. We are under budget at this point during the year, and want to make sure that you understand that. Also add two other things to that. Number one is that we clearly understand the legislative mandate, and I will say this, is that I understand Secretary Cohen's mandate, And I'll say this in eyes, I don't want to disappoint you, but I clearly don't want to disappoint her, is that we will monitor our budget absolutely as tight as possible, and we will make the adjustments to make sure that we will be under budget if we have to do something different. What you'll hear Roger talk about is where we are exactly. We do not believe that we're in a place right now that we should be doing anything other than the state of course, monitor as closely as we can the things that we're seeing, and make sure that we don't see anything that changes radically from what our expectations are. But at this point in time, we're feeling comfortable at the place we're inside the budget. So I'll turn it over to Roger and let him give you all the details here.
Good afternoon. This is Roger Barnes. I'm CFO for the Medicaid division. On there, as Deputy Secretary Richard has said, that we are at the end of September under budget. These expenditures are as of our quarter end in September of 17. While we are a little bit of our spend in the hospital by about $8 million, the others, as you can see, are under their projected in the budget. The other consolidated hospital payments, supplemental payments, cost settlements, the capitation premiums, the total expenditures were under the budget for end of September, about $30.7 million. We have taken the quarter. We've done a quarterly update on our forecast, and that forecast would show that we will continue to be under budget through the end of the state fiscal year on there. This slide shows how our Medicaid revenue is distributed. We thought that this would be good to show that our federal revenues represents about 58% of our total expenditures or revenues that come in, and that compared to the budget, that's approximately we were expecting about 59%. The breakdown of the appropriations actual is about 22% against a budget of about 23%. You can see that the other assessments, rebates, and other revenues are approximately on line with what we had put into our budget. And that concludes our update on the federal. And take any questions that you might have.
Any budget questions? Representative Dobson seems to be thinking hard. Sure.
Thank you, Mr. Chairman. Just to help me understand, or where there's a disconnect between what I see here. The previous presentation, if I'm reading it correctly, was $13 million over budget, and your presentation is saying 0.8% favorable. What am I missing? And I'm sure it's me, but what am I missing there?
Roger Barnes again, sir. Representative Dobson. Yes, I see where you're inquisitive on that. This is as of the end of September. Steve's presentation is as of mid-October. And if I look at today, at this week's check write, we're $11 million under budget. So what you're seeing is a normal variation from one check write to the next. And as we go further out into our forecast to the annual part, we really want to make sure that we will meet our targets of being under budget. And that's what we will do.
Follow up, Mr. Chairman.
Can I let Steve do that real quick, and then I'll follow up?
Steve Owen, Fiscal Research. The only thing I would add to Roger's comment is actually it was what I was using was the check writes through the end of October, but it was only NC tracks. This is a complete picture of Medicaid, including rebates, administrative expenses, non-NC tracks service costs. This has got everything on it, versus what I was looking at was purely just the claims process through NC tracks.
Thank you. That clears up the discrepancy that I had.
One I want to ask, and I haven't seen the specific, and I know it's not the significant level we'd like to be, and I know there's IT systems that are starting to come online now. But our recovery on fraudulent cases and others, how is that comparing at this point in the year with previous years? I know we did some additional personnel and others into the budget, just seeing when that utilization may occur.
Yeah, Roger Barnes, sir. Thank you for the question, Senator Heiss. I don't have that number on the top of my head, so I will need to go back and pull that information. I think we're on pace with the recoveries, however.
Representative Lambeth.
Thank you, Mr. Chairman. Is there a quick answer to the supplemental payments being so far over? Is that just a timing issue?
Again, Roger Barnes. Yes, sir, Representative Lambert, it is just a timing issue. The majority of our payments would occur later in our state fiscal year.
One other question I always like to ask at this point, having been surprised on a few occasions, are there any other expected expenditures of particularly a large nature that we may be in debt to the federal government, or other payments that you expect to be coming in this year that are not accounted for yet in the budget?
Senator Heiss, I'll go ahead and answer that, and Roger can correct. We, as you know, we have constant things that go on in terms of audits and other things. We see nothing in the current year that we believe will impact this budget that we would have to pay back to the feds. And frankly, we're not looking at we'll have anything that's significant that would impact that level. But what I think you can look for is that if there is something, we will come to you, make sure you know that ahead of time and before one of these meetings. But right now, we don't see something out there.
There's history with asking.
So, Mr. Richard, what you're saying is we anticipate that just the fourth or fifth year in a row we'll actually be under budget in Medicaid.
Representative Dahl, I think it'll be the fourth year, but I may be wrong on that. But what I'll tell you is just also a reminder is that this is the most aggressive rebase that we've done in terms of our forecasting. When I say that is that we had a couple of years where frankly it was significantly higher than we would have wanted to return to the General Assembly because obviously any dollars that are rebated at the end of the year are things that the governor nor the General Assembly have the ability to think about and how to use for other programs. So as you know, we were very tight in this effort. So we are optimistic that we will finish that way. As I've said, that Secretary Cohen's been very clear. We will not do anything that goes over, that we will not finish this year over budget. But I don't think you can anticipate some large number of return to the general fund at the end of the year.
Well, I would just to follow up on that. I believe your interpretation is correct as to what we want in the General Assembly. I mean, there were a couple of years there that was nice to have huge dollars coming back because we were able to use those for other things. But to your point, yes, it's much better to be right on budget. And, of course, for the fourth year, we're going to either be under budget or maybe right on budget, which is what we're looking to do. Thank you.
Senator.
Thank you, Mr. Chairman. Mr. Richard, you remember last time I told you Senator Tucker and I were rabid about the fraud. Do we have someone specifically tasked with investigating frauds when it comes to these services?
Senator Kravitz, I remember you saying that, and I was relieved to see Senator Tucker was unable to make it today. We do. I was anticipating you would fill in for it. Yes, ma'am. We do have an entire division which inside of Medicaid that is dedicated to that. It's our program integrity section, and inside of that we have multiple people that are responsible for that oversight and that effort. But we'd be happy to spend a little bit more time on that at some future presentation if you'd like.
Any other questions, comments? Seeing none, thank you. And now we'll move back to Madam Secretary for the status of the 1115 waiver and work plan for Medicaid transformation.
Thank you, Chairman Heiss. So with this part of the presentation, we were going to tag team a bit. Jay Lubin will go through a bit where we are on our timeline and what folks can expect in the very near future. I think you have noticed that we have been, as I mentioned before, been putting out a number of policy papers to help put out as much detail as possible so everyone knows exactly what direction that we're headed in. Continue to take a lot of feedback, which has been really helpful from all sides to help us shape our thinking. We've had very good conversations with CMS to date related to the waiver, those are, again, we're trying to have as much conversation ahead of time before we resubmit the waiver, and Jay will talk through our timing there, so that once we submit, that it can be a pretty quick process with them on the formal evaluation side. And then what we're going to focus on here are two areas of policy. One, again, to focus on behavioral health, and we'll walk through that, and then on supplemental payments. And we focus on those because that is where we still need to work together with the General Assembly on the authority piece to make sure, again, that we are launching managed care in the most successful way possible, which is why we're focusing on those two areas. So with that, I'll turn it over to Jay Ludlam.
Feel free to recognize whoever you wish for your presentation.
All right, good afternoon, everyone. My name is Jay Ludlam. I am the Assistant Secretary for Medicaid Transformation. Thank you, Secretary. As she said, I'm going to do a quick recap of where we are on the calendar, how we're progressing through the RFP process, and then I'll hand it off. All right, so this summer before I arrived, the department published its detailed proposed program design. Internally, we call this the white paper. Comment period was approximately 30 days, where we received feedback from various stakeholders about our proposed design. The team internally took that feedback, worked on refining a lot of our design, formalizing it, and at the end of the summer, early fall, beginning of November, we published 2 requests for information. Those are called RFIs. These are more specific questions that we had for particular stakeholders around our operational design. Some of it is about best practice. Some of it is about trying to understand and assess the potential impact of our design proposal on the operations or the potential costs of the prepaid health plan or PHP, or on stakeholders. We also did something relatively novel in managed care. We released our expected rate setting methodology. This was the actuarial RFI, so we had an operational RFI and an actuarial RFI. It's an important step for us. It's a good thing to put in front of the potential PHPs so that they can assess and understand how we're approaching setting rates. Last week, we released a concept paper around behavioral health, IDD tailored plans, which we'll talk about in a few minutes. And in the next couple of weeks, we'll be submitting our 1115 amended waiver application. What you'll also see from the department over the next couple of weeks and months are more concept papers and potentially more RFIs. As we finalize our operational design, our financial design, we want feedback from stakeholders on what we're attempting to do. And so you should see a number of concept papers around the enrollment beneficiary experience, provider contracting, et cetera. So you should be seeing those over the next couple of weeks and months. We anticipate receiving CMS approval of our amended waiver application in February. And depending on that approval, we intend to release the PHP RFP, which is a request for proposal, in the spring of 2018 for a July 2019 effective date. The RFI internally, it marks a big step for us as an organization. It really marks the beginning of the procurement process for the managed care program. As part of that RFI, we did seek non-binding letters of interest from potential health plans. This is so that we get a sense as to who might attempt to bid on the contract, and whether they'll be acting as regional or statewide health plans. As I said earlier, depending on CMS approval of the waiver in February, we intend to release the RFP for the managed care program in the spring. Just to level set, so the RFP, it establishes the standards. It forms the basis of a contract between us and the managed care organization. It really outlines our expectations of what we're purchasing using our dollars. It will go through such issues such as the plan administration, the quality strategy, and whether or not they need to have offices within the state of North Carolina, what kind of presence they need to have here. What will happen is the managed care organizations will go back and they will diligently write how they will meet our standards. They'll provide us a lot of information about why they are qualified to have our business in North Carolina. And the department will score those responses based on a rubric or a standard that we will outline in the RFP, and that we'll use to evaluate whether or not those whether those managed care organizations are qualified. Also, just so that folks are aware, the state, through the department, will establish capitation rates that the managed care organizations will bid on. Effectively, what we are saying is this is the amount of money that we are putting into the program, and that if you take our business, this is the amount of money that you will be paid through the rate. And that's how that goes.
Great, and I'll take it back here from Jay. It's Mandy Cohen again. And so I'll just make one more point on this because I think I've talked to a number of folks and there's been some confusions because we call it a bid process, so it makes it sound like our managed care or PHP folks who will want to participate in the program would give us the price or give us the capitation rate, but just wanted to be clear that it is we, the state, that establishes that rate, which is why the RFI on that methodology is so important. We want everyone to understand how we are getting to that capitation rate in particular. And again, the competition, if you will, or the competitive part of the process is how the plans show us, the state, that they are going to meet all of the various requirements that we put out for them for them to earn that capitation rate. So I think bid process is often misunderstood as if they're going to come up with the price. Rather, they're going to prove to us that they can do a set of services for the capitation rate that is based on the methodology that we've released. And so with that, I just wanted to, at a high level, talk about where we are with behavioral health integration and our current thinking. And again, recognize that this is a place where we look forward to some action with the General Assembly on how to move forward. I've been talking about for a number of months about how we went through a process of looking around the country, really to try to bring all of the best thinking, the best work around the country here to North Carolina. We are the largest state that hasn't moved to managed care, which puts us in a good position to learn from a lot of other states that have tried this. And really what we are seeing is that a lot of states are trying hard. If they haven't already integrated physical and behavioral health, they are rapidly trying to do that. Some are finding it harder because they have had a system that has been fragmented for so long that the delivery system has become entrenched, and it's actually hard to bring it together that they know that's where they're trying to go, and it's taken a fair amount of time and money to get it back together. So, we really want to make sure that when we are launching managed care that we're doing it learning from the best of what is around the country, but also recognizing the strengths that are here in North Carolina and the work that has been done by this General Assembly, by Chairman Dollar and others to do the work on the behavioral health side and the work that the LME MCOs are doing on the ground already. So that's where all of this comes. It's taking those best practices from around the states, but making it work for what is here and the infrastructure that exists here in North Carolina. And at the most basic, it is about having a single point of accountability, one insurance card, no matter who you are. If you have your primary diagnosis is a behavioral health one, or you are a mom or a kid, you have one insurance card that encompasses your entire healthcare needs. And so the idea is that once managed care is fully implemented, those Medicaid beneficiaries receive coordinated physical and behavioral health services, and again, with one insurance card. The way that we are moving forward with this, our nomenclature is around standard plans, which is essentially what moms and kids would be enrolled in, with a smaller number of those folks who have significant behavioral health or IDD needs being enrolled in tailored plans. And so we're going to walk through, and Dave Richards is going to walk through the details of this, but that is the paper that we put out last week that goes through our thinking on who are the folks that are going to be those in a standard plan versus a tailored plan, what is the benefit package, what is the enrollment procedure, and such. So that's some of the detail we'll walk through here. I just want to remind you of the time sensitivity for this action. Again, Jay went through the timeline here, and we really do want to go through a procurement process starting this spring. Again, we want to do that and launch this with in the most successful way possible, and that means launching with a capitation rate. Again, we said we, the state, set those rates. We want to set a rate that includes both physical and behavioral health. So we need to know that that's the direction we're headed. That is the work we are trying to do right now, is to set those rates. And so in order to do that, we need action from the General Assembly to say, yes, go forward in this direction. When you put out the competitive process in the spring for PHPs, please do, put the physical and behavioral health together. So that's the time sensitivity here, is like to keep on that schedule. We are going to need action and give direction to us in the department, which to proceed here. But let us walk through the details. Dave will do that, and then we'll be obviously happy to answer questions.
Thank you, Secretary Cohen. And I'll go through each one of these slides. We won't go through all of the words on there. But just to sort of reiterate what Secretary Cohen has talked about in terms of the standard plans. And as you think about that is what you would think about as you pass the legislation to go forward with managed care. These are, I think, how most people think of we're doing. So there would be the statewide plans along with the regional PLEs. And these organizations would be responsible. We want them responsible for making sure that the physical and behavioral health needs of the people in those plans are met through those plans. Now, we sometimes say it's a mild population their population for needs for behavioral health services would be inside these plans. I think the way to think about it is that a different way to think about it is those individuals that don't have severe and persistent mental health needs or severe substance use needs or developmental disabilities or part of that TPI waiver. Those folks would all be inside of our standard plans. And if there was a need for a behavioral health service, and I use the example of somebody who has a chronic disease and they need counseling because of that. I have had heart disease my life, and having that counseling was an important thing for me when I first learned about having heart disease. So let's say it's something we should have through one insurance plan rather than having to go through a separate system to get to that point. It's really what we're trying to get here, is that they would include those plans that are standard for all Medicaid beneficiaries except for those individuals that would be included inside the tailored plans, which are those individuals who have significant mental health needs, significant substance use needs, and those people with IDD and those folks on our TBI waiver on the waiting list. One other point in this is that I want to be clear, and I think people will talk about this a lot, is that, so what does that really mean at the level? What we really want to have happen for folks is that you have the ability for integrated care. We talk about that a lot. What I would say, and I think we all know this, by putting people into one plan doesn't necessarily guarantee that it'll happen at the clinical level. But if you don't do it, I think what we do is guarantee it will never happen because it's so difficult for people to try to use two separate systems to actually get to that integrated level at the clinical level. And on the tailored plans, which is where the white paper that just came out, or the concept paper that just came out that you all hopefully have had a copy of it. We've got others, but it describes in great detail how we believe the tailored plan should look. And the reason why we wanted to spend a lot of time describing that is because I think the more you understand about what that view is, it's easier to understand the standard plan side of this. So what we're really speaking to is that a specialized plan that targets a large group of beneficiaries, about 120,000, that have those severe needs. And again, I think when I think about it a lot, it's those folks that when I think about what LME-MCO does, that's really who I think about, the people that they're supporting right now, is that really intense need of individuals. That's the folks that are getting those intense services that have significant needs from behavioral health and developmental disabilities. It would be an integrated plan. It would include both the physical health spend and the behavioral health and the developmental disability spend for those individuals. So, as Secretary Cohen has mentioned, one card to get those services. So providers would all be a part of that plan, and people would be able to go to those service providers. We want to make sure that the beneficiaries can access a network of providers that the full array of services. And again, when we talk about that, is that so if you have a significant substance use disorder, your provider that you go to mostly might be that substance use provider that does that work. But boy, isn't it for those individuals, if we can make sure that the ability to receive their physical health care in an integrated environment at that substance use provider level, or at least something that is an easy referral, we know that the benefits of those individuals are going to improve, and certainly their health status will improve as that happens. We're thinking about the anticipated rollout of this is that the standard plans obviously would go as we say July 1 of 19. The tailored plan population would be delayed, and what we would hope to do is to keep that population in current fee-for-service while we finally developed by the tailored plan, did our RFP for those plans, and that process was finished, so that they would then, those 120,000, if you will, individuals would move over to those tailored plans at that point. Real clear, we want to do this through a competitive bid process to ensure that entities can meet both the requirements for behavioral health and physical health. And we'll talk a little bit more about that, but just to mention the competitive bid process, why we think it's so important, is that we know, and I think you all know, is that as individuals are thinking about designing a plan to support folks, if they know they have to compete with other people to do it, they're going to put their best foot forward. They're going to design the plan that makes the most sense. They're going to respond to what makes the most sense. And it's going to be something that they have to really work to get to. Our LME-MCO system, as Secretary Cohen has described, is one that we are very proud of. Lots of very good things have happened through that system. But one of the things that hasn't happened is that it's been an exclusive franchise for individuals. So we believe that the ability for a competitive process will make us better, and one that has, again, all spend for individuals inside of that. Now, we've heard a lot of folks say, well, when you do that, you're going to have these really high capitation rates because you have people with the most severe needs inside these plans. And that is correct for that small number of people. And just a reminder of how we do LME-MCOs today is when we set our capitation rates for LME-MCOs, it is based upon all Medicaid-eligible individuals, not just the people that they provide services for. So it's all Medicaid individuals. So the capitation rate, the PMPM that we keep talking about, will sound relatively low compared to what it will be in a tailored plan, but the actual dollar amount is not going to be that significantly different. We don't anticipate, in fact, we know that this would not cost us any more. Over time, it will surely cost us less because of the integrated nature of this. But when you hear that, people say, well, we'll have a much higher capitation rate. Yes, it will, because we'll have a smaller population that we're basing that on, and it would be a population with a higher risk that people serve. But today, we just mask that because we show the capitation rate of the LME-MCO system across the entire Medicaid population. So in the concept paper that came out, we overview of the populations covered in standard and tailored plans. And so we've had a lot of conversation about this. And so we went through a detailed list of the ICD-9 and the ICD-10 diagnosis codes associated with each one of these populations. Would include the IDD population, the serious mental illness, the serious emotional disturbance, and substance use. And also included that is those people that, again, mentioned on a TBI waiver or would be on a waiting list for that TBI waiver. We include a detailed list of the services covered only by tailored plans and a list of the services that will be covered by both plans and tailored plans themselves. And then we go through a list of how the enrollment process will work. So how do people wind up in a tailored plan to begin with? How they stay in a standard plan? And then obviously during the course of a year, people will move from standard plans to tailored plans because someone may have a need for those really intense services that will be inside there. We cover those mid-year transitions and how the renewals go. We also have information in there that's really important around care management and how we view care management because it's such an important role for people who have these significant needs inside of this plan. You shouldn't be able to read this unless you have really great glasses, but this is a list that you'll see inside the slide deck that describes both the standard and tailored plan services that each would have inside of it, and then a list of those that are covered exclusively by the tailored plans. And the goal, what we're trying to achieve here, is to make sure that if you're in a standard plan and you have a need for mental health services, you can get those services, right? Even if they might be more intense services. If your needs wind up being significant enough that you would meet the requirements to be inside of a tailored plan and need those additional services, you would move in to the tailored plan. So if you see on my right side is that these are services that you would generally think about for those people that have long-term needs for support, both who have behavioral health needs and those individuals who have IDD and, again, the TBI service that are available. As Secretary Cohen has described, is that we know we have to work, and we are hopefully continue to work with the General Assembly. And I would add that all of the stakeholder groups that are important here. So it's not just the behavioral health constituencies and the DD constituencies, it's the medical communities and everybody else that's involved in this to make sure that what we've put out inside of this concept paper makes sense, and it makes a sense for the populations that are being served. So we anticipate a robust effort to work with folks around the tailored plans in particular to make sure that we've got all of those things right. We also know we've got to talk about the governance structure for IDD and tailored plans. We know that the conversation around LME MCOs in their current state, how that looks, and their ability to be a part of the tailored plans is a really important concern. We believe that LME MCOs have a really important role in this, and we want to make sure that as we're talking with you that we define that appropriately, so that would include things like the governance structure that would have to be a part of the tailored plans. And again, in this we highlight that we do anticipate LME MCOs would submit bids, and many of them would be thinking about, and I think they're thinking of today, of how they would work with a physical health plan to serve as a tailored plan. We also know that we put out in our original white paper an idea about what the regions will look like, and the fact that we would have just regions and no statewide plan. It's something that people have come back to us in our feedback to say, we want you to think about more. So we know we have to work with you and the other stakeholder groups around to determine what would be the best design for that. I think the important part of this slide, and to reiterate what Secretary Cohen said, is that for our standard plans, we believe that we have a wide variety of people that believe that's the right way to go, and we need to have that done as quickly as possible so that we can bid that when we bid the standard plans. We want to work with you and as stakeholder groups to make sure that we are getting the details correct and these things important inside the tailored plans as we move forward. I should stop there. That was the last slide.
Representative Dobson.
Thank you, Mr. Chairman. Three questions, if I may. First one to Madam Secretary, if I can. You talked about the capitation rates, or the capitation rate. If we're going to set that before the RFP goes out, normally when an RFP goes out, you go with the lowest bidder. At least that's a major concern most of the time that you factor in. If we're going to set the capitation rate, what metrics will be using to determine who gets those 3 statewide contracts?
Great question. This is Secretary Cohen. So we measure them against a standard of can they deliver the services for our population. So if we say we want you to deliver physical and behavioral health services, they have to prove to us they have a network of providers to do that. So they'd have to show us how they are contracting with the doctors and hospitals to, if they're going to have a statewide plan, for example, they'd have to prove to us that they have the network that can be able to do that. We'd ask them to do things like show us how you're going to do care coordination. And so they'd have to show us here, this is our plan for care coordination. I mean, and it's a gamut of hundreds and hundreds of standards like that, and then we will have a rubric, as Jay was mentioning, we will have a scorecard to say, well, you get 10 points for network, 10 points for care. I'm making this up, everyone. Back there who's listening to every word I'm saying. Right. We will have a rubric, which will be very transparent. It'll be in the RFP to say that this is what will give you extra points. Right, we want to see, these are things that are non-negotiable. Either you have them or you don't. You do not pass go, right? Or you don't even get into the next stage. And then the next stage will be, these are the things that are going to inch you up towards the ones that will get selected. So you don't compete on price, you're competing on quality. And I think that is the way most states do it. Now, some states, and I was mentioning this to others, do say they sometimes have a band of, say, the capitation rate, I'm making this up again, is $87, $88, $89. And so they're going to say, oh, I can do this for $87, or you know what, no, I really need $88. And we found from other states that feedback, really didn't bear out in terms of either getting better costs or better quality for folks. So we are going through a process of really using the best actuarial science that we can to build our capitation rates based on the historical data that we have, and then asking folks again to meet the standards that we've been articulating in our first paper and in all of these technical documents, and then we will select from there, and it'll be, this is why I'm excited that Jay is on the team. This is someone who's been through this and has supervised these kinds of bid processes before.
Thank you. Two more questions on a different topic, if I can, Mr. Chairman. Mr. Richards, on slide number 9, further work to develop behavioral health and IDD tailored plans. You talk about non-Medicaid federal grant dollars will be managed by the tailored plans, thus only nonprofit or governmental entities will be able to offer them because of that non-Medicaid federal grant dollars. What type of entities other than the LMEs could you imagine, not specific names of organizations, obviously, but what type of entities could you envision perhaps taking this on?
Representative Dobson, I think it's a great question, and what we saw in this is that there are certainly health plans that are nonprofit health plans. There are health systems that are nonprofit health systems that could be a part of this. But I think as we continue to have these conversations, is that we believe that one of the right combinations would be a combination of a health plan or some other thing with an LME MCO to be able to do this work, because as we described, the idea of building upon what works in this system is something that we want to do. So those are potential options that, as we currently envision it, would be there. But again, that's the work we want to do with you.
Thank you. One last follow-up, Mr. Chairman. On this same issue, if you envision this going forward through legislation or however we can get there, is that the permanent solution going forward for the tailored plans?
Representative Dobson, we should have anticipated this question a lot. I would tell you, here's what I believe, and is that ultimately the state of North Carolina will move to a system that requires that our managed care plans manage both behavioral health and the physical health needs of individuals, because it is ultimately the right way to get at integrated care. You can do all the other things you want to do, but eventually if you don't have people responsible for the full cost of care for an individual, the obstacles are significant to get there. And we know that's better care for individuals. So what I believe is that for North Carolina at this point in time, this is the right answer because it builds on what we've done. I don't think that we can ever say never that there wouldn't be another iteration. But I believe if we do this, what we've done is we've set the course that is something that we can build upon, continue to use to make sure that we get the best services. So no guarantees that it's the last part, because we've had a lot of reform in mental health, I know. But I think if we make this step, then what we can do is stabilize the system, stick with it, make sure that we're continuing that process, and we should be able to do that hopefully for a long period of time.
Thank you, and I would share that. I think the sooner that we can get to a as permanent can get solution, so everyone will know the path forward, I think the better. Thank you, Mr. Chairman.
Thank you. Just to let you know, I have Representative Lambeth and Representative Dollar, Senator Krovic, Senator Pate, and Representative Murphy. Questions, and did want to point out there apparently is another slide on supplemental payments that's coming in. We'll cover. I don't know that that'll be the big question area, so that's coming in. So we'll go ahead and run through these questions and then cover that before we leave. Representative Lambeth.
Thank you, Mr. Chairman. There was no mention in here of the development of metrics that would eventually reward through incentive system. Is that in the process you're developing those metrics? It was just an oversight in here.
So there will be a separate paper on our quality strategy as well as our care management, and that is where we will use some tools, both incentives and carrots and sticks around incentivizing quality, yes.
One additional question, Mr. Chairman. One comment had that would include statewide commercial plans and regional PLEs, and I believe the plan actually allows the statewide to be both commercial and or PLE plans. And you might want to make that correction on the slide.
Good catch. Yes, thank you.
Representative Dollar.
Thank you, Mr. Chairman. I have a number of questions. If you'll just let me kind of go through them a little bit. Okay. I'll try. I'll do my best. I mean, to be very candid, as you know, Madam Secretary, I'm not sold on all of the changes that are being proposed here with respect to the LME MCOs. And the reason why I'm not is that this is something that we've been investing 6+ years, actually 6 years prior to that, in a pilot, and then when we made the passed the law in 2011, and then subsequent legislation. And I would point out it keeps getting said, and I wish it would not be said. We have managed care in behavioral health now. The LMEs are local management entities, managed care organizations. So we have that now. And we also have one card. I'm not sure what the magic of having one card is, but we have one card now. But I want to ask several questions, and I probably don't have time all afternoon to ask all of the questions that I've got. But when you say best practices, when the department says best practices from other states, which specific best practices? Do y'all have some specific best practices? Because I know there are times when you go to another state and you talk to them, and they'll tell you a good story about whatever their program is, and that is not necessarily what's going on the ground. So I'm particularly interested in which specific best practices, as it directly relates to ID and DD services you're talking about.
Sure. I'll start, and then I'll have Dave jump in here. I think we spoke last month that where we were looking towards was the state of Arizona that has done this work, and actually the National Governors Association has now put together a collaborative on best practices in behavioral health, and they've highlighted three states, I believe, Arizona, Michigan, and one other. So validating to me that they are also looking at 2 of the 3 states that we looked towards for best practices, and how do you think about the financing side to drive the results that you want on the delivery side. And we've been able to connect with the Arizona team, understand how they thought about their work, and I think that is helpful, but I think importantly, we want to recognize, to your point, the infrastructure that we have here. You are right that we are doing a version of utilization management or managed care in the behavioral health side. Folks do still have to have their physical health needs authorized by the state, or would in the future by another managed care entity. And so I think as we move into managed care, I think our responsibility is to look at what's going on well in other states, but then adopt it to what is the reality here in North Carolina. And that's why I think you see this plan that is unique. I think it is unique to North Carolina because it builds on the capacities that we have here. And so it takes those principles and best practices that's in Arizona. It's not exactly the same. I will say Arizona does not have governmental type entities that would be part of these plans, for example. That's just not their governance structure. But again, they did not have the type of LME MCO infrastructure before they made their change. So again, we're trying to adopt to what we see here, but yet still bring those same principles and the same structure. I don't know if Dave wants to add more.
I think I'd add just a little bit. I had several conversations with state Medicaid directors across the country recently and at other times. And I think what Secretary Cohen had said early on is that many states that have started out with a carve-out or in their fully gone managed care, they're trying to figure out today how to make sure they integrate those populations. That seems to be you can't, just say this way, you can't go to a conference with Medicaid directors without that being a topic there. There was clear indication that integration of behavioral health and physical health is the not only the trend, but it's the best practice for states to go forward. I think that I would add, because I know you mentioned the IDD population. It's really interesting. I know our system looks an awful lot like what Michigan's system looks like. It's one of the things that was brought in as we did that. And the Michigan director, they are moving toward trying to integrate their current behavioral health DD system with physical health and with behavioral health and DD service together for the very same reason that we're seeing, is that we have a system that is frankly, again, does really good things for certain parts of our population, but what it can't do is create that alignment between the physical health spend and the spend for behavioral health and developmental disability, and it creates quality issues in terms of how we do the work inside of that. But what I'd say, Representative Dollar, is that it's hard to find a state in the country that isn't trying to move toward an integrated model.
Let me ask you this. We could debate more on that issue in terms of quality and what's actually being done in those. Who is actually going to provide? Currently the LME MCOs, and a number of them have done this, and we could bring them up and have countless examples of community investment. And I'm talking about in the millions of dollars in community investment in facilities in certain cases, and in other cases services that are provided for because of how we have designed the system in North Carolina. I see nothing in what I've read, and of course, last week y'all sent the additional paper at the end of the week, so I haven't been able to fully analyze that. But I have not yet to see, for example, where you're going to generate the money and how it's going to be generated specifically for community investment. And we have serious problems in this state and this country in terms of mental health and mental disease issues and behavioral health issues. And if we don't have some mechanism, it seems to me then, the General Assembly is going to have to come up with somebody's going to have to come up with the money to do that. Where is that community investment in this plan?
Representative Dahl, I'll start. I know Secretary Cohen has thoughts on that. One of the things that I would clearly anticipate is that, so if you are a tailored plan and you are responsible for the total spend of a population that has significant mental health needs, substance use needs, and developmental disability needs, you're going to be looking for your community investment. You will be doing community investment because the best way to provide service to the individuals, as you know, if you've been around for a long time, is that we use all fancy words around on social determinants of health and those other kinds of things that we use, but that's going to be the place to where we're going to get the best bang for our dollar as people begin thinking about how to use the entire Medicaid dollar along with those state dollars to best serve the population. And this is I think the reality is that incentives work, right? So if we're creating a system where we're telling these organizations that you are responsible for the total spend of these individuals. You're responsible for the outcomes that we've put out for those folks. And if you don't meet those outcomes, we're going to either give you carrots or sticks, as the Secretary described it. Then they're going to invest in the things that will make their outcomes better. And that's what we want to see. And those won't be siloed investments. They'll be investments that both address the physical health needs along with the behavioral and developmental disability needs.
Well, that all sounds real nice and good, but it's not the real world in many respects. I mean, you have to have specific facilities to address behavioral health needs, whether it's children or adults that are behavioral health needs. Otherwise, the hospitals could do the whole thing, but they're not designed for that. I mean, you have specialty facilities now, and not just the long-term residential ones that you have. So somebody's got to be able to make those specific investments. And when you talk about the population, we say, okay, and this is something that we've talked about, and there may be some coming agreement, maybe, on saying that mild to moderate services would be billed under the larger capitation. And obviously a lot of physicians and others would like to be able to do that for a host of very good reasons, and reasons of integrated medicine and the like that I think everybody here supports. But when as a practical matter, you back those people out of the capitation, as you mentioned, Mr. Richard, earlier, that means that quote-unquote capitation for the LME, MCO, or tailored plan or whoever is going to go up greatly. I mean, and with a lot of the IDDD folks, I mean, you're talking about a great deal of just fixed cost. It just is what it is. And although I think they're doing an excellent job right now of trying to manage what, particularly quality of life issues and stuff, what people are receiving, still, we are taking away part of the area in there, and that the way that capitation works, in which they're able to realize additional funds for that community development. And before somebody says, well, we don't think that's the way it'll happen, dang sure going to have to show me numbers that that's not a legitimate concern with what we're talking about doing.
Representative Dahl, this is Dave Richard. I think I appreciate all of your comments, because I think those are things that we need to be able to respond to and give you great detail on. And I think as you review the paper, you'll see a lot of those things addressed, and we definitely want to continue that dialogue. But let me give you an example of where I think you begin thinking about the reason why integration makes sense, and the other places to where folks save money. And you're very familiar with the ICF program for people with developmental disabilities. And for others, it's a program in which let's use the community side, mostly 6-bed group homes where people live inside of there, and the entire spend for the developmental disability services, except for medical, are included in the cost of that service. Right now, we pay a capitation rate to the LME MCOs, who then contract with the ICF providers based on a rate that they give to them. And that capitation rate is designed just to provide those services for the individual in the group home. When an individual in one of those group homes winds up in a hospital, and it happens often, they've got significant needs and do those things, the LME MCO no longer pays for anything at that ICF, because the individual is now inside of a hospital where the Medicaid rate's being paid from fee-for-service. While they're in the hospital, they don't pay, but we continue to pay the capitation rate to the LME MCO, because that's how we have to do it in terms of make the rates sound for those individuals. Well, if we had an integrated system, and here's where I think that where we begin thinking about these kinds of examples that actually show you how we can not only do what's right for the individual, but improve the cost outlook for how we do business. Right now, and I say clearly, I don't think there's an LME MCO in the state that thinks this way. But right now, if I'm not paying for a person when in a hospital, I have very little incentive to provide additional support for that group home, or to make sure that that individual gets out the hospital quickly, because right now it's being paid for by pure Medicaid fee-for-service. If we stay in the system we're in right now, it'll be paid for by a separate health plan for doing those things. If we're all one total cost of care, I guarantee that the managed care organization had the responsibility for that would be doing everything in the world to get the person out the hospital quickly, because the cost of living in that home is a lot less expensive than a hospital stay. It's better for the individual. And we wound up aligning the actual financial incentives with quality incentives. And there are multiple places inside our system where we can sort of show that. Now, again, I'll say clearly, I don't believe anybody at the LME MCO system is trying to do a cost shift, but there's a natural cost shift that happens the way we do business today. So I think some of the things you're concerned about in terms of that investment actually get addressed in creating the right incentives with the financial and quality standards.
Well, and I would just, and I know you want me to wrap up, but and I haven't scratched the surface of the questions that I have, but let me just make two quick observations. One on that, with the current system, we control the capitation rates. So if you believe there needs to be an adjustment to adjust for that, you can do it on an annualized basis. Y'all can look at those costs and you can say, hey, look, you're realizing something here, and we don't like the investment, or we don't think we'll adjust that. You won't have that if you move to the system that you're talking about. You won't have the hands-on control nearly as much as we currently have with managed care in the public sector managed care, the way we currently have it. And the other thing, I would just make this observation, and that is when we talk about integration, particularly with behavioral health, it's not simply a matter of physical health plus whatever the behavioral health issues are, which can be quite a range. But you're also talking about integration with public schools, juvenile justice, DSS, and a whole host of non-governmental agencies, private groups, and the like that are all involved with behavioral health at the community level. And we have a lot of integration, a lot of connections there that I think that I'm just not seeing the valuing of that in all of these proposals. I keep seeing that, well, we got to have the money up here, and we got to get this money up here. But in behavioral health and mental health, if you don't have that network out there, and if we do things that take away folks that are trying to pull all of that together at the local level, we will have lost something very, very important in this state that goes back decades before even the LME MCOs now, going back to the areas in the counties in terms of behavioral health. And we need to make sure that we don't, in the pursuit of other sometimes very worthy goals, that we don't lose, we take sight of what we might lose.
No, I was just going to say, I think that those are excellent points, and we've kept up this slide on the further work here, and I think that is what are the guardrails that we need to put on this, both from a governance structure as well as a spend and an expectation of what these tailored plans would be expected to do in terms of partnership with local entities and such. And so I think we are aligned there, and it's a matter of let's do the work of articulating what are those guardrails, what are those parameters that can take us to the next step here. I think these are the kinds of issues that we want to get out on the table.
Members, I had a request. Representative Murphy has another commitment and would like to get a question in before he has to leave. I'm going to take some prerogative here and let him really.
Thank you, Mr. Chairman. I appreciate that. This isn't nearly as erudite as Representative Dollar's comments, but I just wanted to ask, just when we're talking about when we're sending out the RFP for these companies, and they're going to be sent it out and they're going to tell this is how much it's going to cost. Are we going to look at how their expenses are going to be done? In other words, we're now moving into managed care, and now we're moving into an administrative cost that previously had not been heretofore. And so we have 93% of the providers. We're very fortunate in the state of North Carolina that participate in Medicaid. I just want to make sure that all of a sudden now we're not going to have an administrative blossom of costs, and we're going to lose providers from the system.
I think that's a great point, and it's something that we think about a lot in terms of the burden on the doctors and other clinicians in the system as we make this change. Right now we have one payer. In the future we'll have more than one payer, so that by design that means that there's going to be more complexity in the system. So it's incumbent on us at the state to think through what are the ways in which we can reduce that burden as much as possible. And so there's a number of ways that we've been talking about, whether it's unified credentialing or other way, a unified quality strategy, so every plan doesn't have a different quality metric, right? It's all the same. We have a standardized drug formulary, those kinds of things that at least we can have some standardization for our doctors and providers. So I think and we welcome feedback and help. What we've been asking, the folks who give us feedback all the time, help us prioritize, like what are the hardest, biggest pain points for folks in terms of administrative burden, to make sure that we're prioritizing those, because we're never going to be able to do everything, so help us prioritize. So that's one. On the administrative cost side for a managed care entity, just know that we do have the specific structures as we build our rate methodology, that we outline how we build the administrative dollars that will go into that capitation rate. But I would say we also cap how much a managed care entity can spend on administrative dollars versus clinical dollars. So it's you have to spend it at least 85%, and did I get that right? At least 85% of your dollars on clinical services as opposed to admin. So, right, so we both create a rate that reflects the need for administrative dollars to run the program, but then we make sure that 85% of those dollars go into clinical care.
Thank
you. Senator Krovic.
Thank you, Mr. Chairman. Actually, the astute representatives asked my question, but as a free market capitalist businesswoman, I like the word for-profit. So Representative Dobson beat me to it, wanting to know why the nonprofits were bidding on the tailored plan. So thank you for the presentation today and the information. It's great.
Senator Pate.
Thank you, Mr. Chair. Very interesting conversation. Are we certain that we've covered all the bases? Are we going to suddenly find that there's a group of people who are suffering through their lives that have not been covered, and suddenly are they locked out, or is there some way of getting them in? And I'm specifically talking about TBI folks.
Mm-hmm. I think that's a really good question. And one is the reason we're trying to be as transparent as possible down to the individual diagnoses codes is so that everyone is very aware of, who's in what bucket, and give us feedback. Like, this is the time, give us feedback if we're not recognizing service needs. We think we did a very thorough job, but always welcome additional feedback to say, this diagnosis really belongs in this category versus that, which is why we did it down to the, like I said, the individual diagnoses code. Plus, we also outline a process in which if we got it wrong, and that will happen, right? That things will happen, that we have a process to rapidly address that. And so we outline that process as well. But again, we want to take feedback on that. Is that the right process? I think we want to make sure that we are building processes that are as focused on those that we are serving as possible. And I think it goes back to the question Representative Dobson asked is this going to solve all the problems? And I'm never going to sit here and say that it is. I think we're trying to do our best to look at the best evidence possible, build on what's working here in North Carolina, and then execute a plan that we are being very transparent about, that we're getting as much feedback as possible. There's a lot of competing thoughts, so we're trying to find the right middle ground to move the whole system forward, and then we'll adjust. And that's my pledge to you, is to continue to be transparent, to continue to look at data, to continue to be responsive to those that we serve, and then if we need to, we will adjust.
Thank you. Representative Ensko.
Thank you, Mr. Chairman. And I have also a series of questions. I'll try to put them in order. And I know it's 3:00. I would like to just start by saying that I have a great deal of respect for the work that our LME MCOs have done, and I understand that we have other states coming into North Carolina to find out what they've been doing, because they've been doing managed care with this difficult population for a long time. And so I hope that we don't lose the best of what we've got. My concern has to do with maybe two groups of people I could put those into. I don't know how many people that you see. You said 120,000 people would stay in the tailored plans. I'm not sure how many people that carves out what percent of our current population that is. And let me just, I don't know what's going to happen to the uninsured. Where are they going to go? If we lose our LME MCOs, it all goes into standard plans. Eventually, they won't be covered. I don't know who will be responsible for them. I don't know whether we'll have people in the traditional plans that will want to do provide housing is a service for mentally ill people. If you live under a bridge or in the woods, you aren't going to get consistent housing. And so housing is a actual service. A job is an actual service. And so I don't know, that to me a lot of that doesn't fit into our traditional health plans. And so part of my concern is that also, will we have state facilities? I mean, who will take the people to the emergency room and then to the state facilities? I don't see how all of that eventually works together. That's kind of my general area of concern. But if you could start with saying, will the LME MCOs eventually go away? Will they disappear into the system?
Representative, this is Dave Richard. So I think what we've been trying to say, and again, I appreciate Secretary Cohen's point about we want a lot of feedback on this, right? That's part of the reason why we put out there. We believe that in this plan that we put forward, there is a pathway, the right pathway for the LME MCOs to be a partner in this effort, and we think that will be one of the important ways in which we evolve this system. I think I'd take a quick step back and to say that in terms of the word tailored plan is actually, I think it's the exact right word for what we should do. A lot of people use specialized or specialty plans, but this is trying to design to be tailored around the population that you described. So you're right. Housing is so important for people that have significant mental illness. It's important for the folks to have transportation. But the reality is the LME MCOs today don't provide housing directly. What they do is they use contract agencies to do that work. The LME MCOs, through maybe the Transition Community Living, our DOJ settlement, have a responsibility for certain housing activities, make sure it happens. But we frankly have a really great partnership with our housing finance agency to do that. We don't see that changing in a tailored plan, is that the responsibility to make sure people are inside of housing, that's part of the that's part of how they do treatment and the other services, that'll be part of the tailored plan support. Right now, our uninsured is paid through by our single stream dollars and the other IPRS, as we used to call it, the money that goes through. That's why we say state and federal monies will be with the tailored plans, because that's where that money should go. So they'll have the opportunity to provide it. We of course know that is at a premium in terms of how much money we have in terms of those state dollars. Those state dollars, at whatever level the General Assembly appropriates, need to be in those tailored plans because they're tailored and designed for those people with the most significant needs. So we don't see that as something that would be part of the standard plans because it's for those individuals at that level. I think, Representative, so what I would add, and again, your incredible history of working on these issues, I know how passionate you are about that, is that I would say that the people that have been working on this effort inside the department and our engagements with folks that are outside have the same level of passion for you. We would not be proposing something that we believe would not be better for those individuals that have those significant needs. And the reason why we suggest a tailored plan is because we want to make sure that the care management, the care coordination, care management is appropriate for this population and not that individuals get lost in a larger plan. So our goal is the same that you have, is to make sure that we continue the really good things that have happened, but at the same time improve by creating a total cost of care model for these individuals so we address their physical health needs at the same time as the behavioral health needs.
Maybe I could get this information later. I'd really like, thank you, specifically, could I get more information on exactly what these other states are doing with these specialized populations, and what is the evidence that they're actually doing better than what we would be doing now?
Dave, Richard, we're happy to do so.
Thank you. Any other questions, comments? One quick question I had and then a comment. When we talk about getting this waiver approved, and we understand that there is a short timeline the legislature needs to act in this process, but what is the value to CMS of integration? They're the ones we're going to ultimately have to negotiate with for approval for our system, and I know you, Secretary, have some pretty extensive experience there. They manage this nationwide. What do they see the value of integration of mental and physical health within a plan, and how important is that to their ultimate approval of a plan?
Yes, so they have been extremely supportive and have given us good suggestions on even how to further refine the work that we're doing, but definitely think that we are headed in the right direction in terms of integrating physical and mental health. They've been telling us stories of other states who are having to, go back, amend waivers or redo processes to bring these together now, and that it is hard, and don't go down that path. I do not anticipate having any issue with them approving this piece. As I said, they've done it in other states and are encouraging. It's almost, as Dave mentioned, there's almost no states that aren't moving in some part of their Medicaid program in this direction. So if anything, they would caution us against not doing it. And again, that comes from both a clinical outcome and a budgetary outcome from their perspective. So we've gotten a lot of support and, in fact, good suggestions on, again, how to just refine things at the edges.
I guess just for a comment before we move on to supplemental payments to wrap up, for most people it's aware I'm kind of on the other side of this issue, and I have felt from the beginning that it was important to move all of mental health under a single system. We're going to divide this stigma and others of saying, how we carve out certain needs and others, but move it as a covered service and place it under a single system that we can put in responsibilities for overall plans. And people who fail the mental health population need to have at risk losing the entire population they serve in their contract to make sure they provide those services. But I am, I do understand, I think, the need that we need to move quickly. And while this is not the gold star of where I think we ultimately need to be, I think it is an incredible step in the right direction. And I think it's reached a point that I think I can make some of these agreements for myself and support ultimately a plan that goes to this step that's coming in. But I will say that I also think that we've heard a lot of rosy things about the LME MCOs. And I will say, having done the budget for the last couple of years, there is another side to this. We've talked a lot about investment in communities. Well, I've seen a lot of investment in fund balance that was coming in with entities that build a fund balance larger than the state of North Carolina, and not until we begin to make significant cuts to that do we see any plan for how those would be reinvested on the community. I am approached by advocates for different individuals with disabilities on a regular basis here that will tell me how the system is currently failing them, how their services are being handled and managed. And I think we all know we can do better for the population with severe and persistent mental illnesses. Those are the things that I think that once we can bring their physical health together, once we can bring all the dollars on the table to be able to manage their care, I think we're in a position to do that, and we're in a position to create a system with performance measures that make sure that occurs. So, we got a lot of work left to do, but I remind everybody we got a short period to do it in. So, moving on then, next slide we said would be supplemental payments.
Sure, and this is Mandy Cohen again. I'll be very quick on this. And again, I bring this up as just another place where we're going to need partnership with the General Assembly on action. I mentioned this at our last meeting, but work has continued, and you will see again another white paper on this with a lot of technical detail behind it within the next few weeks. So I wanted to make sure I brought it up here. But just to recap that I mentioned last time, we need to make a change in the way in which we pay hospitals. Right now, we pay hospitals for with supplemental payments that sit outside of the actual direct delivery of service to our Medicaid beneficiaries. And CMS has written rules since the managed care legislation was passed, and has written rules to say, sorry, you can't have supplemental payments sitting outside if you are going to move to managed care. And in fact, earlier this year, the Trump administration put out some clarifying guidance related to those CMS rules, basically to say we're interested in flexibility of these rules, except for supplemental payments. So they were very clear that they intended to hold to this rule, that not having supplemental payments sitting outside of our managed care work. So the hospitals have been tremendous in working with us to find a solution here, because this is where I did not think CMS would approve our waiver unless we came up with a plan that had us bringing those supplemental payments into the managed care program. And the way we do that is, if the payments are sitting out here sort of off to the side, we have to build them into the rates, meaning we have to put them into the capitation rates, so we have to put them into the actual rates in which we pay for individual services. And Roger can talk to you about more details if you're interested. But essentially, that is the plan we've been working with the hospitals, is what do those rates need to look like, and what it's come down to, in order to make sure that we're not doing too much disruption of the way hospitals get paid. We essentially need to do hospital-specific rate floors for every single hospital here in North Carolina, and we're willing to do that technical work. So I think we have a good plan, but there's a ton of technical work that we will put out over the next few weeks behind that. But again, I just wanted to reiterate: one, we don't have this is the rule. Like, if we want to have CMS approve our waiver, we had to go in this direction. Second, we've had a really good process with the Hospital Association coming up with the plan to minimize disruption. And then third, I think this I see this, again, as an opportunity for us. As we move to managed care, I want to make sure we're moving our system to a place where we can drive more value out of every dollar. And if you're tying dollars to the direct delivery of service, you're able to really use your value levers in a much more concrete way than if the payments are sort of sitting off to the side and are not quite as connected to the actual delivery of service, which it will be as we move forward here. So I think that we're in a good place. Again, we'll need some work with you all on just authorizing how we do make these changes, but we'll put out the more technical detail. And then it probably makes sense either in December or January session to come back and answer questions on the technical detail. But I think we're in a good place there. But again, we'll need some authorizing legislation to just make it all happen. So why don't I stop there and answer any questions?
Questions on supplemental payments? So
I got a question on something other than that.
There's a few I wanted to ask. Just as I'm reading it real quickly, does this in effect lock all hospitals into fee-for-service? Or can the plan, because I know there's the same rate for fee-for-service and others, how much can plans vary from the floors in order to put in incentive payments and guarantee the overall dollars, but how much flexibility do they have within that?
Yep. So it'll create floors, but it won't change your ability to negotiate with the individual payer. There will be some restrictions in the first couple of years. Again, just try to retain some stability, but then free up on the latter half of our waiver period more of that negotiation. And this is where I anticipate, and we are encouraging our future managed care entities to move to alternative payment models very, very quickly. Those are things that take a little bit of time to sort of gel and get right over time. So I don't anticipate seeing those internal alternative payment models out of the gate day one. Maybe we will. But I think, again, year 2, 3, 4, we'll start to see some of those alternative payment models and moving away from fee-for-service. And, in fact, I think this accelerates that process, if it makes sense. Roger, do you want to add anything?
Roger Barnes. Sir, to what you're seeing and why we put up there that the fee-for-service and the managed care rates would be the same, it's primarily to help with administratively. Currently, our hospitals' base rates are $27.04, but once you add in the supplemental payments, they can get as high as $7,000 per discharge. So what we did not want while we're transferring or transitioning from fee-for-service into managed care to have some of those fee-for-service payments at the $27.04 and the managed care at the $7,000. We still have the carve-out populations that we will be dealing with. Now, all of this we are designing, working with the hospitals to make this as budget neutral as we possibly can. And this is where we will be looking at possible legislative action, and that is at what tax percentage rate would we want to look at, and do we need to refine that the assessments, hospital provider assessments legislation that's currently in place.
Any other questions coming on supplemental payment? If not, I know we're 2 minutes over, but Representative Dollar needs the last comment. So.
Thank you, Chairman. No, I was just going to suggest that maybe what we, based on your final comments and the other discussion, is can we invite the heads of the LME MCOs to come to the next meeting and give them an opportunity to talk about what they've done, but also ask them questions about reserves and other issues and populations they're serving, and maybe populations that folks have concerns about.
Just to respond, I'll look for, as we set the next agenda for coming, I think that's about the 8th time today you've said we need the LME MCOs in front of us between both committees that's coming in. But so I understand what you're pushing, so we'll work on it. So.
Thank you.